Asante sana.
Your Excellency, the Deputy President, the Kenya Kwanzaa leadership, all distinguished guests who assemble here today, including our host, the Catholic University, I'd like to first express my appreciation and express my gratitude on behalf of Kenya Association of Private Hospitals for inviting us to this forum. My name is Dr. Timothy Olweny. I'm the Secretary General of Kenya Association of Private Hospitals. I'd like to share a few perspectives. I had a brief presentation which was shared, but apparently they have some challenges with projection. So I'll just speak off the cuff. Now, in terms of what we would request anybody who potentially is going to be in government is in terms of certain changes that would improve our healthcare system. For example, universal health. Universal health coverage is one of the topical issues and one of the most important things. So there has to be measures put in place in terms of accelerating the achievement of universal health coverage. Now, just to elucidate a little bit, the term universal health coverage is not necessarily fully understood by everyone. Universal health coverage has got three important facets. First, in terms of providing equitable access. It's not just access, but equitable. In our country at the moment, we have got access in general, but it's not equitable in terms of, there's a lot of regional disparities in terms of accessing healthcare. Access to health services and the entire range of health services that are required, but also they have to be of sufficient quality to be effective. Because in the absence of them being of sufficient quality to be effective, at best we can talk about universal health care, but not coverage. Now, one of the things that happens whenever we try to push towards universal health coverage is one of the easiest things to increase is access. So for example, if overnight we got the resources and we said the entire population can be able to go to health facilities and get health care, health system capacity cannot increase overnight. And so what has happened, even in our case, in the time when we have had this push towards UHC, is that quality has dropped. Because health system capacity you cannot train health workers, for example, you cannot build facilities and have the diagnostic facilities and so on overnight. Then in addition to that, there's the issue of financial risk protection. And this is one thing that the earlier speaker, especially Dr. David Ndii, brought up. We cannot be exposing people to financial hardship on account of procuring health services. And the only way that that is going to change is if we change the system via which we finance healthcare. Now, healthcare financing, for example, to achieve UHC, you can have two approaches. You can have a tax-based approach, where the government primarily is the provider of healthcare through taxes, and then you can also have social insurance as a vehicle, which is the avenue we're trying to use in Kenya. Now, in the absence of us having a pooling system where we're going to pool resources, we will never get rid of the issue of people being impoverished as they seek healthcare. So the pooling mechanisms can be through, for example, tax-based systems or social insurance, as I said, but we have to eliminate the issue of paying for healthcare at the point of service. So we have to have a pre-financing mechanism, and pre-financing mechanisms only work when you pool resources, either through social health insurance or through private insurance. Out-of-pocket payments need to be eliminated. In fact, in our country at the moment, I think the data that they have from the medium-term report on the Kenya Health Sector Strategic Plan said that still we have got 8% of our households that are spending monthly more than 10% of the total health expenditures on healthcare. And that goes all the way to the point where we've got people who are being impoverished by procuring health services. The social health insurer, that is NHIF, there have been a lot of reforms that have been proposed of late, and it is in terms of trying to increase the pool or the base of people who are contributing to this fund. Now, insurance is about keeping your promise. And I don't think there's going to be any way, and I challenge anyone to, if you're going to put a mandatory system and say you're going to start arresting people who don't have NHIF insurance if they can afford to pay for it. It has to be that we deliver value and people see the benefits of belonging to this system. And NHIF has periodically has fallen short of this promise. And that is a challenge. Now, you have got the biggest challenge they have in terms of financing. You talk about mandatory contributions, yes. But the challenge is, and especially during the COVID period, we saw that there was a significant reduction in the voluntary contributions because people just didn't have the money or didn't see the value. So you've got people who contribute periodically when they perceive they're going to benefit. And that aspect of adverse selection is what even private insurance companies complain about. So people go and procure insurance when they anticipate a need. And after that has been taken care of, then they stop contributing. So one of the things that we have to do is look for a way in which we're going to have consistent contribution towards this scheme. And that's why the issue of the indigent people, I don't like that term very much. I think people who are, I'll say, economically disadvantaged should have contributions provided by government. So that's one of the ways in which we're going to increase the tax pool. But even as we talk about employers also contributing or matching their contributions that has been suggested, we have got to see an increased milieu of benefits. And that is what we have not seen in the current system. We have seen enhanced contributions, but we're not seeing the enhanced benefit packages being rolled out. Now, I've talked about out-of-pocket payments. Now, the other thing is the rising cost of healthcare. This is one of the items that we have got to handle and handle decisively. There has to be a systems approach in terms of dealing with this because it is not a simple fix. I come from the private health sector, and we have always been the bashing people, boys. When it comes to cost of healthcare, they say private hospitals are the ones who are charging too much. But the inputs, if you look at healthcare as a product, the inputs that produce that product, a lot of the time, we don't determine the cost of those. And that's why there has to be a collaborative effort and a concerted effort to bring down these costs. For example, it is not a secret that since, for example, we had unionization of healthcare workers in this country, the costs of payroll and costs of employing health workers have gone up. And that is a fact. We've got other inputs. For example, pharmaceutical supplies are a significant component of the health bills we pay in this country. Why is it, for example, that when you go to a place like India, we pay for the same branded drugs that you'd buy here for 3,000 shillings, you can get it for 600-700 shillings. I had an experience like that as a doctor when I went to a hospital in India, and I started looking at the packaging, wondering whether it's a genuine product they had given me, and I could see the pharmacist getting irritated, because for me, I could not believe I was getting it at the price I was getting it. So in the absence of us having a manufacturing sector that is robust, in the absence of government somehow entering the fray and trying to be able to regulate the prices of these commodities, we are not going to control the costs of health. In addition to that, there are other drivers of healthcare costs. All commodities. For example, government has a role to play. We have got a lot of taxation right now on a lot of the inputs that are coming in for the health sector. We cannot say that we are trying to promote universal health coverage, and yet at the same time, we are taxing the inputs that are going to bring down the costs of healthcare. I come from the private health sector, and we have seen in other sectors, for example, the government gives incentives. You've got people who get tax holidays when they come and invest. And the rest of us who are local investors are sitting and wondering, why would the foreign investors get preferential treatment over us? And if I was a foreign investor, before I come and invest in a market, I want to see how that government is treating its own people, because that becomes a reflection of how I'll be treated a short while down the road. So the cost of healthcare has got many facets, and that needs a concerted effort in terms of bringing down costs. One of the other major things is the mechanisms we have for healthcare provider compensation. For example, the traditional method, especially in the private health sector, has been fee for service. You walk into a facility, based on the inputs that are used in terms of providing care for you, a bill is generated, and that's how you pay for it. At the other end of the scale, the extreme end, we have got a system which we call capitation, where we decide that there are a certain number of people we want you to take care of their healthcare needs. We decide on a certain amount, we provide it to you, and in that way the risk has been transferred to you. So that's a capitation system. In the recent past, we've also got a fixed fee for service system, which especially private health insurers have been trying to introduce, and which the private sector feels is very unfair in the sense that they're transferring the risk of taking care of the clients to providers. And a lot of the time without notifying the clients that that is what they're doing. So you're told, we'll pay you for every outpatient visit 2,500 shillings. The person who is coming for care has not been told that's the arrangement, but what happens is the tendency is people try to reduce the costs of care per individual, and therefore quality of care goes down. And that is something I think we should not encourage in our system. The other thing which determines the healthcare and where government has got a major role to play is what we refer to as social health determinants. There are certain things, for example, socioeconomic factors that have been known to be